Good afternoon. Welcome to the webinar organized by the Malaysian Chamber of Commerce, Hong Kong and Macau. Today's event is something that's very close to our heart. Apart from having a good heart, you must have a healthy heart. And that's the reason why we came up with today's event. For this event to happen, and we are very grateful for Gleneagles who co-host the event with us. And we are very fortunate that to have Gleneagles, to have Dr. Michael Chan to make the presentation for us. Before I introduce Dr. Michael Chan, I'm going to first introduce Ms. Joyce Smith. Ms. Joyce Smith is the Head of Business Development and Marketing of Gleneagles Hospitals in Wong Chuk Hang. So as we know, Wong Chuk Hang is on the south side of the Hong Kong island. We're very close to Ocean Park. And without further ado, I'm going to introduce Joyce to introduce Gleneagles Hong Kong to us. Thank you, Joyce.
Thank you, Lawrence. Okay, on behalf of Gleneagles Hospital Hong Kong, thank you for joining today's webinar. And we would like to use the opportunity to introduce you our hospital. Let me share the screen first. Okay, Gleneagles Hospital, I think this brand shouldn't be new to you. In fact, our mother company, ACCIAHA, is a regional player. We have our footprint in 12 countries, 83 hospitals, and operating over 15,000 beds. And Gleneagles, this brand name, is actually under one of the wholly owned subsidiaries of ACCIAHA, which is the largest operating subsidiaries of ACCIAHA, we call it Pak Hei. We have footprint in 6 countries, including Hong Kong, Singapore, Malaysia, and also other countries, and with 31 hospitals and over 6,000 licensed beds. And we start our operation down in 2017, which means we are more than 3 years old here in Hong Kong. And other than having Pak Hei as one of our mother group, we also have a strategic partnerships with different institutes in Hong Kong. It's more like a tripartite partnerships, including Pak Hei, New World Holding Limited, and also Hong Kong Health System. New World is actually one of the listed infrastructure and servicing flagship of New World Development Company Limited in Hong Kong, and they have an extensive experience and good track record in constructions. And that's why we're bring us this beautiful hospital. And at the same time, for the University of Hong Kong is one of our key partners in providing our hospital with clinical governance, and also we are affiliated training hospital under Hong Kong system. That is how strong our background and our partnerships between these 3 institutes. And in 2020, for the 2nd consecutive years in 2020, we are being awarded as the Hong Kong Living Award 2020 Best Hospital, voted by the Hong Kong Living readers. Majority of them will be expatriate in Hong Kong, and they found our service up to their standards, and they appreciate our medical service provided here. At the same time, as one of the newest hospitals in Hong Kong, we actually won the Management Innovations of the Year in 2019 of being innovative and bring new inspiration in the healthcare industry in Hong Kong, including but not limited to digital platform, all-inclusive package, and other initiatives. At the same time, we are not only serving our Hong Kong residents, but also our Greater Bay Area clients, and we are being ranked the top 50 best hospital around the region. Now we come to some of the service introductions of Gleneagles Hospital Hong Kong. We actually introduced the first concept of all-inclusive medical package, which means that for one single pricing, everything will be included, including the hospital charges, room and board, all the procedures fees. And if there is any unfortunately with post-op complication, all the associated charges within the length of stay will be covered. So it brings the patient a peace of mind and can estimate their budget a bit more precisely before the admissions. Okay, now we come to our hospital premises. I would love to bring you to look around, but unfortunately, because of the COVID time, if the situation improves, we would love to bring you to have the hospital tour here. First of all, let me show you our inpatient rooms. Our inpatient rooms, actually, we are the only hospital in Hong Kong, even for the standard class, our most basic class, is equipped only with 2 beds. We've giving enough privacy and space to patients. Actually, we trust that a better environment for the patients will promote recovery as well. Of course, suitable for different needs, we have semi-private single or double bed, private or even junior or VIP suite, depends on our patient's choice. About the facilities, we are the first and the only private hospital on Hong Kong Island provide round-the-clock emergency medical services, which means we have our emergency medicine specialists to be on site all the time to help our patient in need. At the same time, we have our specialist outpatient clinics. We have 4 centers of excellence, 16 specialist outpatient clinics, and more than 35 specialties and subspecialties. And our speaker, Dr. Michael Chen, is one of the core in our cardiology unit. Of course, other than treating illness, we see health well-being is one of the core and the essential part. That's why we have recently renovated our health screening clinic to give a closely and one-stop environment for our clients. As a hospital, we also have our endoscopy center, our cardiovascular lab. Again, it is one of the key areas that Dr. Chen work on. And also we have our first and the only private behavioral health clinic and inpatient services in Hong Kong, because we see mental health as important as physical health, and we do hope to bring in quality medical services to patients in need in that aspect. At the same time, for patients who need radiotherapy or with cancer cases, we have a comprehensive radiotherapy sections and also chemotherapy center. By end of the year, we will have a particular ward subspecialized in handling all oncology cases, helping to bring in more and more attentive care for our patients in need. At the same time, we have our day dialysis center for renal failure patients. As a hospital, we have our operation theater, we have our clinical laboratory with a fully automated track system, and also radiology center with all equipped with advanced technology, including but not limited to PET-CT, MRI, CT scan. And one of the very important thing is, other than a normal standard ward, we also have our critical care unit, which is very important for cases which need intensive care. Last but not the least, understand the needs from the patients. Sometimes they think that, oh, if you have a service point away from Mojo Town, maybe closer to Central Area, that would be good. That's why we have recently relocated one of our satellite clinic in New World Tower, which is site at the heart of Central. And the service hours will be on a Monday to Friday, 9 in the morning to 6:30 in the afternoon. And also on Saturday is half-day services. And we hope to bring in primary care and some of the specialties to serve there and provide more convenient location for our clients. Last but not the least, because of the recent relocation, we have quite a good deal on some promotion offer, including some health check, flu vaccines, and also HPV vaccines. If you are interested, please check out on our website or just scan the QR code for details. And this is the end of our introductions, and I will pass the time back to Lawrence.
Joyce, thank you for the time, and I'm very pleased to see such a beautiful hospitals in Hong Kong, because it looks as beautiful as an hotel already. Next, I will share the agenda for today. I'm going to introduce Dr. Chen when he's ready. But before we do that, the agenda will be that Dr. Chen will make the presentations, and we would like you to send in all the questions that you may have in a Q&A, and then Dr. Chen will try to answer the questions as we go along. And just for those who are members of the main cham, please be reminded, actually, we do have special package for MACHAM members for the health screening package. I'm aware that we have many members who actually use a package and sign up for it, and they were very happy with it. And if you don't have, I'm going to ask the secretary to send out a link again with the details of our patients. Dr. Michael Chan is the Honorary Clinical Assistant Professor in Cardiology of the University of Hong Kong and is currently the Consultant Cardiologist in the Gleneagles Hospital Hong Kong. He's the Fellow of the Hong Kong College of Cardiology and the Hong Kong College of Physicians, the Hong Kong Academy of Medicine, Royal College of Physicians of London, Royal College of Physicians of Edinburgh, Royal College of Physicians and Surgeons of Glasgow, and American College of Cardiology. He obtained his doctorate degree in medicine from the University of Hong Kong in 2017. And his thesis titled Stroke Preventions in Atrial Fibrillations and Atrial Fibrillations Screening to Anticoagulations. Prior to commencement of the private practice, he has worked for 14 years in the cardiology divisions of Queen Mary Hospital and as a consultant in cardiology in the University of Hong Kong St. John Hospitals. His expertise includes percutaneous coronary interventions of complex coronary artery disease and minimally invasive transcatheter valve therapies, including transcatheter aortic valve implementations and left atrial appendage occlusions. Dr. Chan has published over 60 peer-reviewed articles in major cardiology journals, including JACC and Circulations. He is also the pioneer in Hong Kong for conducting community-based screening for atrial fibrillations and setting up emergency 24 hours angioplasty service in public sector. So I think we are very, very fortunate today to have Dr. Chan to share with us this hour. And please do feel free to send in your Q&A after the talk, or as you have, please do send it in, and Dr. Chan will try to answer the questions as much as he can. So without further ado, I would like to invite Dr. Michael Chan to take over. Michael Chan, please.
Thank you, Lawrence, for the kind introduction. So it is actually my great honor to be here to share with you our expertise, some cardiac problems, and it is actually very important not only for people with cardiac problems, but also for those who are healthy individuals, because cardiovascular disease is actually largely preventable. So today we're going to talk about some cardiovascular risk factors as well. So so let me start today's talk. So with the first slide, you know that when you flip through the newspaper, you very often read the news that some people would actually present with sudden cardiac arrest, sometimes maybe after strength exercise. And it is actually quite a common topic, in particular during the marathon season, that some people may unfortunately have a cardiac arrest or admitted to the hospital because of such a cardiac emergency. So actually, the myocardial infarctions and sudden cardiac death as the first presentations for findings of cardiovascular disease is actually quite common. According to the Framingham heart study, actually more than 50% of the men presents with such an acute event. And of course, over 40% in women, slightly less the men, that presents also as acute event. So not every people would have a chance to present to their doctors to receive treatments before such fatal disease is detected. And of course, we are talking about cardiovascular disease. What does that refers to? So basically, that includes coronary artery disease, cerebral vascular disease, including stroke and transient ischemic attack, peripheral vascular disease, and previously, Lawrence, as you have mentioned, that atrial fibrillation, one of the most common sustained cardiac arrhythmias, is also included in the cardiovascular disease. Hypertension, largely due to the hardness of the arteries, and also congestive heart failure. So we're going to focus on more common cardiac diseases today. So I'm going to talk about coronary artery disease as well as some cardiac arrhythmia issues. So most common cardiovascular disease, of course, is coronary artery disease. The developments of atherosclerotic plaques, of course, is not in everyone. So basically, if we have some risk factors such as cigarette smoking, hyperpressure, high cholesterol, then of course these kinds of fatty streak will slowly develop in our blood vessels. Of course, coronary is one of the most important structures because it supplies the blood to the heart muscles. And when time goes on, that is accumulations of all these fatty streak resulting in a rich lipid core, and eventually, if some kind of unfortunate event that these kinds of rich lipid core with cap that can actually rupture and causes acute events, leading to myocardial infarctions. What we mean is heart attack. And of course, cardiovascular disease, depending on the timing, depending on the presentations, and they can present with the stable angina. And of course, some people would have acute events. They can present with unstable angina, myocardial infarctions. Of course, if it affects other sites, such as the low limbs, that it can present as peripheral vascular disease. Of course, if it affects our brain vessels, then of course it can lead to transient ischemic attack and stroke. Coronary arteries is actually one of the top three killers in Hong Kong. So if you count every 11 fatalities in Hong Kong, 1 died from coronary artery disease. And in every year, over 4,000 of people die from coronary artery disease. And of course, men is more affected, largely earned because of the relatively lack of protections, because of the menstrual, because of the during the reproductive ages before the menopause. Women are largely protected because of the hormonal protection. The male is more affected from the cardiovascular disease, including stroke and also the myocardial infarction. In terms of the risk factor for coronary artery disease, and of course we mentioned about sex, actually advancing age is also one of the important risk factors. Family history of premature coronary artery disease, including those men who are less than 55, female less than 65, high cholesterol, high sugar level, and high blood pressure. And of course, the presence of the peripheral vascular disease, being obese, and metabolic syndrome, these kinds of problems, and also premature menopause is one of the important risk factors for coronary disease in the ladies. Diabetes mellitus, because today we're going to talk about cardiovascular prevention. So it is very important if we focus on those common cardiac risk factors. Diabetes mellitus is one of them. So if unfortunately you have diabetes mellitus, meaning high sugar level, usually the definition is the A1C, HbA1c higher than 6.5. Then it is a diagnostic test for diabetes mellitus. When there is a higher HbA1c, meaning that the diabetes is more severe, then the chance of you suffering from myocardial infarction, stroke, or heart failure, or peripheral vascular problem is higher. If you manage to control your diabetes, of course, these kinds of macro and microvascular disease risks will be lower. Hypercholesterolemia. So, of course, we know that our liver tends to produce a lot of cholesterols. So these largely is for storage, for transportations of these energies. But of course, we don't want the bad things too much. So the LDL, what we regard as a bad cholesterol, is one of the things that we want to get rid of, in particular for those with coronary and cardiovascular, cerebral vascular diseases. And HDL is actually one of the good things that we want to apply a little bit more. So it's potentially anti-inflammatory. So according to the large studies, that the higher the LDL level that you had, the higher the risk of suffering from coronary and cerebral vascular diseases. And according to many of these primary prevention studies as well as those secondary prevention studies, we see that the lower, if you can achieve for the LDL level, the risk of event rate will be much lower. That means it formed the basis of why do we need to take some of the medications, including most importantly, statin to lower our cholesterol level. This is the American guideline published 7 years ago. So statin is recommended in forming groups. It remains valid nowadays. So first of all, adults with clinical atherosclerotic cardiovascular disease, meaning that those with coronary disease diagnosed, those with stroke, myocardial infarctions, will belong to this group of clinical atherosclerotic cardiovascular diseases. So meaning that if you're suffering from heart attack, then you receive an angioplasty, of course, you have to take statin at least. From the evidence currently, you have to take these medicines lifelong. Adults with LDL level 4.9 or above have to take statin because usually among these group of people, there is some of these genetic impacts on the LDL level. No matter how hard you exercise and how hard you restrict your diet, it might be quite difficult to get to the optimal level. And the third group belongs to those patients with diabetes. If you have diabetes, the chance of you suffering from cardiovascular and cerebrovascular diseases will be doubled compared with those without diabetes. Of course, statin therapy can help to lower such a risk, together with a tighter control of diabetes. The fourth group belongs to those people who are regarded as high risk based on the ASCVD estimated. Usually these belong to relatively middle-aged and elderly people with underlying hypertension or other risk factors such as cigarette smoking. Then these people might benefit from statin as a primary prevention strategy. And according to the 2013 guideline, there is no LDL or HDL treatment target. But now we have some of the newer emergence of the evidence that the lower the better. And nowadays, for those people, say for instance, those with coronary artery disease, we try to aim at levels of less than 1.8. And even for those very high risk people, we even want to achieve a level of less than 1.4. This is our current evidence-based practice. And also, this is what in accordance with the 2019 American guideline, European guidelines. The American guideline largely follow such a tight control of LDL level. And actually, it mentions use of one of the novel treatments, PCSK9. It is an injection form of a biological treatments that helps to lower the LDL level roughly by around 60%. It is a very viable alternative for those people who cannot tolerate statin. So it's usually in the injections form. Of course, patients can self-inject it for these PCSK9 treatments every 2 weeks to up to every 4 weeks. Hyperpressure. So hyperpressure is very prevalent. In our locality, it is estimated around 35 to 40% of the adult population suffering from hyperpressure. So in accordance to the previous guidelines, usually for those with a blood pressure higher than 140/90, it is regarded as a hyperpressure. But nowadays, we largely follow a tighter control, which is published in 2007, 3 years ago. The American guidelines advocated that for those people with blood pressure above 130/80, then they are regarded as hyperpressure. For those people where the older guidelines said it is defined as hyperpressure, according to the new guideline, it's already regarded as a stage 2 hyperpressure. So meaning that nowadays we are looking at a tighter control. And why is that so? It's because all the new evidence point to benefits of having a tighter control, resulting in less and less cardiovascular events. So that's why in those who can tolerate the medicines, we recommend actually, in particular also the younger subjects, we recommend a tighter control in order to prevent recurrence of the cardiovascular and cerebrovascular events. Ambulatory blood pressure measurement is a very valid clinical tool for the diagnosis. I guess many of you have encountered seeing a doctor with a high blood pressure at the clinic. So it's very often that this office blood pressure and the clinic blood pressure is not too valid and as a reflection of the blood pressure, because it tends to be affected by the mood, by the anxiety level, and also maybe you're rushing to the clinic to see a doctor, then your blood pressure must be high. So ambulatory blood pressure can actually give us a very valid assessment of the blood pressure. So in general, if our average blood pressure is higher than 130 and/or the diastolic blood pressure over 80, then it is regarded as high blood pressure. But of course, not everyone with high blood pressure will need to receive medicines immediately. It depends largely whether there is coexisting cardiovascular problems or concomitant diseases or target organ damages. Say for example, if a person is diagnosed with high blood pressure and he or she is suffering from myocardial infarctions, then of course we have to monitor and treat the blood pressure more tightly rather than loosely to allow the lifestyle modifications to work. Cardiovascular disease preventions focus on several the strategies. So of course, as a cardiologist, we often see people with established cardiovascular diseases. That means we can only employ a secondary prevention strategies. Secondary prevention meaning that patients already had established cardiovascular disease. Primary prevention is largely based on the modifications and also the optimizations of all those risk factors. But I would like to draw your attention to the primordial preventions, because preventing the occurrence of these risk factors can actually prevent you from suffering from cardiovascular disease in the future. So primordial preventions is actually the strategy that all of you should establish. In order to achieve that, of course, we try to reduce the risky behavior, such as reducing the salt intake for those who are taking salty foods. The chance of you suffering from hyperpressure is much higher. Reduce amount of the fat intake and also sugary food would help to prevent obesity. And also for those people who don't exercise often, have to exercise more, because that can actually prevent all those common risk factors such as diabetes, high blood pressure, and also high cholesterol level. So this is an important estimator. So this is based on the recommendations of American College of Cardiology. So if you want to understand yourself a little bit more, then prepare some of the important parameters such as your cholesterol level, your blood pressure level, age, sex, and also whether you're smoking or not. Then after you input all these important parameters, you can derive the roughly estimated risk based on this calculator. Then you will receive a recommendation whether you need to receive some of the important pharmacological strategies on top of the lifestyle changes. So what are the symptoms of cardiovascular disease after we mentioned all those risk factors? If unfortunately you suffer from chest discomfort or some of the symptoms such as breathlessness or cold sweating, then pay attention, because that might be reflections of underlying cardiovascular disease. Of course, those with chest pain can actually be suffering from some of the gastrointestinal problem as well. So how do we distinguish? You know, the heart is responsible for pumping the blood to the rest of the body. So of course, during exercises, we have a high demand of the blood supply. So during the treadmill test, we can actually review whether there is any symptoms of angina of the tested subjects. And sometimes if we want to have a more accurate assessments, we can have other tests such as CT coronary angiogram. CT coronary angiogram is just like showing us the picture, how does the coronary artery looks like. It actually provides a much higher accuracy than the treadmill test. But of course, it is not a test for every subject. It's not a test for annual screening. So basically, it is a test ordered only for people who are suffering from some symptoms, such as chest discomfort, or for those with angina. And the beauty of the CT coronary angiogram is within a short period of time that you can have a nice images of your coronary. It can assess the degree of stenosis. Usually we say in those people who are having a stenosis of 70% or more, and if they are symptomatic, then we will recommend revascularizations, usually in the forms of percutaneous coronary intervention. Of course, drawbacks of having a CT coronary angiogram is a mild radiation. But nowadays, with faster scanner, newer generations of the scanner, the radiation can now be minimized. So you see that the radiation exposure is now we're even talking about less than 1 millisievert. And you can see the nice images that we can achieve from having a CT scans. Of course, you see from the top left corner that it is a very severe narrowing of the proximal left anterior descending artery, correlating to the picture D on the real-time invasive coronary angiogram. Of course, these patients need a stent for that area. MRI perfusion study and also Myocardial SPECT study can actually assess the amount of ischemia. And some people would actually have a moderate narrowing, not to the degree of severe narrowing. And sometimes the symptoms may be very vague, and it might be difficult for us to judge whether he or she is suffering from real angina or not. Then in that scenario, myocardial perfusion scan in forms of myocardial SPECT or MRI heart scan can actually evaluate the presence of ischemia. If in such case, this patient is judged to having ischemic lesions, then revascularizations again on top of the medical therapy is indicated for such patients. So in general, how do we treat coronary disease? So everyone will shout, oh, stenting, but actually this is not the case. It is very important, and also the focus of today's talk is risk factor management. If we don't control our risk factor in a good manner, then of course our coronary disease or cerebrovascular disease is prone to recur. And medications is also very important. Angioplasty stenting is not going to replace medication. So for everyone who even receive a stenting to the coronary vessels, he or she has to take medicines for long term. Of course, the malarities of the people, usually I would say around 0.5 to 1% of the people, that's with a very difficult coronary anatomy that we cannot tackle with percutaneous coronary interventions. Then these patients are referred to the cardiothoracic surgeons for coronary artery bypass surgery. Of course, coronary artery bypass surgery can achieve a complete revascularizations. But nowadays, some of the data show that the morbidity perioperatively and also the mortality is higher, largely because of the wounds and also associated stroke risk post-operatively. And of course, patients will take much longer time to recover because of the large operations and will usually stay in the intensive care unit for much longer time. Of course, PCI nowadays in some of the countries can be performed as a day case. We usually would admit the patients for percutaneous coronary intervention the same day and then perform the procedures on the same day. Usually only one night stay to observe the wound for any potential complications and bleeding. And usually the next day the patients can be discharged home without any problem. Of course, for percutaneous coronary interventions, we face the problems of restenosis. But nowadays, with the latest generations of drug-eluting stent, the chance of restenosis can be lessened to around 1 to 2% per year. So percutaneous coronary interventions, most of my patients perform these have these procedures performed under local anesthesia. So they don't need a general anesthesia or deeper anesthesia to have this operation done. Usually, most of these patients will have a wound through either the right radial or the left radial artery. And of course, the lesions will be crossed with the guide wire, with the balloon inflated, and eventually the stent implantation. And of course, afterwards, the patient has to take important medical therapy, including antiplatelet therapy. So this is to show that how we move the catheters from the radial artery all the way up to the heart and engage the coronary vessels to achieve a successful recanalization of the vessels. So for stents, we all know that we need to put metal framework into our coronary arteries to make the coronary vessels patent. Otherwise, those lesions after ballooning will prone to recoiling and restenosis. Latest generations of the drug-eluting stent can actually have the minimal restenosis rate. So this is an animation illustrating how we do the percutaneous coronary intervention. So the guide wire is through, and you can see the blood cells. Now it's like the train going into the stations. So the balloon is inflated at the site of the narrowing. And of course, you notice there is a little bit of the recoil of the lesions. But after the stent went in, the vessel is kept patent largely. So of course, the balloon catheter will be removed afterwards. So during the procedures, we not only depends on our eyes to assess the lesions, we also performed intravascular ultrasounds as well as optical coherence tomography. So for these kinds of intravascular imaging, it can give us a very accurate information on the lesions and also the severities of the lesions. So this is one of my patients who had a total occlusions of the right coronary artery. And after recanalizations and also the images with the optical coherence tomography, the stent is nicely placed with 3 scaffold placed in these right coronary arteries. So I'm going to share with you an acute case, Ms. Wong, who attended our hospital A&E department. So she is a 67-year-old lady with a background of hyperpressure and diabetes. She presents with some of the atypical discomfort, epigastric discomforts after dinner. Of course, you think that these patients may suffer from indigestion, but sometimes if you miss to perform an ECG at A&E departments, then you miss a heart attack. And these patients actually suffer from acute myocardial infarctions in the anterior wall. And when I go in with the emergency coronary angiogram, you can see the almost totally blocked proximal left anterior descending artery. And with the timely revascularizations and putting a stent in, you can see the vessel is recanalized and remains patent. And of course, with the timely interventions, which is very important because Joyce mentioned that in the Gleneagles Hospital that we have the A&E officers working 24 hours, 7 to ascertain that these patients who present sometimes maybe having atypical symptoms will receive timely interventions and evaluations. So this is very important because if we don't diagnose and treat it timely, then usually after a few hours, that the heart will suffer from structural changes. The golden hour for heart attack treatment is within 90 minutes from door to balloon. So meaning that for patients who attend A&E departments, when he or she have symptoms, you have to treat and open the arteries within 90 minutes. If you don't treat it timely, of course, eventually the heart will suffer and of course resulting in heart failure because the muscle cannot regenerate by itself. So this is the first part of the talk, and so I'm going to have a touch on the most common cardiac arrhythmias. I know Many of you would have the experience of having some palpitations, but not all palpitations means atrial fibrillations. Atrial fibrillation is only one of the most common sustained cardiac arrhythmias. But of course, sometimes when you have palpitation, it may be because of the stress, maybe sometimes some of the trivial arrhythmias such as occasional ectopic beats. But of course, atrial fibrillations warrant your attention. Why is that so? It is not only the most common sustained cardiac arrhythmia, but it can potentially cause us problems by forming clots. You can see from these animations that the atrium, in particular the left atrium, is fibrillating. You can see that the atrium is moving and contracting at a very high speed. Inside the atrium, because of these fibrillations, rather than a very effective contraction, the blood cells will tend to form clots. And you can see that the clots formed in the left atrium can travel all the way and leave the heart and go up to the brain vessels. So these kind of blood clot formed in the left atrium is particularly large and also can potentially block the proximal part of our cerebral vessels. If you've got occlusions to these, one of the branches or main cerebral vessels, then of course, that unfortunate persons can suffering from stroke, acute ischemic stroke. The more proximal parts or the larger the clot is formed, then the more severe the stroke is. So in general, how can we make the diagnosis of atrial fibrillations? Of course, some of the general investigations included an electrocardiogram. But sometimes they are paroxysmal in nature, meaning that you just have atrial fibrillations for a short period of time. But for other period of time, then you remain in normal sinus rhythm. So handheld device is very important because nowadays we have Apple Watch and also some of these devices called Cardia. So very often you have the experience that you might have some palpitations, but when you're going to see your own doctor, your family physicians, or even your cardiologist, at the time that you see them, that the rhythm has already returned to normal. It's very frustrating because you can only base on the estimations or guess to make a diagnosis. But of course, we need a documentation of the rhythms to initiate treatments, appropriate treatments. So the presence of the availabilities of these handheld devices, Apple Watch, can actually help us to make the recording at the times of having symptoms. So it actually helps also in my projects of early AF detections, because I use these kinds of devices to screen in the community for atrial fibrillations, because they are very easy to use, handy, and they can be applied to lots of people. So how do we manage the atrial fibrillations? When you have the atrial fibrillations, of course, how do we treat and whether to give treatment depends on the presence or absence of symptoms. Rates of rhythm control can be applied to these patients who have symptoms. But if you don't have any symptoms, the focus will be on stroke prevention. Because whether you have symptoms doesn't mean that the stroke risk is lower or higher. How do we assess a person who have atrial fibrillations, whether he or she will be suffering from high or low risk of stroke? It depends on the calculations of risk factors. If you have high blood pressure, high cholesterol, high sugar level, previous stroke, or myocardial infarctions, or when you are having an advanced age, then these patients are regarded as a higher risk of stroke. Then either you have to receive anticoagulants, usually in the form of new oral anticoagulants, rather than warfarin, or left atrial appendage occlusions. And what is that? Previously, you saw from the animations that most of the clot is from the left atrium. In particular, for these patients with non-morphic atrial fibrillations, the clot is actually formed from the left atrial appendage. By occluding and obliterating the left atrial appendage, the clot can be prevented from forming and escaping from the left atrial appendage, and thus stroke can be prevented. So this is a minimally invasive surgery performed under monitor anesthesia or local anesthesia. So basically, there is a device inserted and put in the left atrial appendage and occlude the site so that the clots will not form and escape, and so that stroke prevention can be achieved. These patients with successful operations can be exempt from taking long-term anticoagulations. The second important management is how do we achieve optimal rate control. Some people with underlying atrial fibrillations would have a too slow heart rate or too fast heart rate. And sometimes not only the medications will work, but sometimes they may also need a pacemaker implanted. Of course, you have some knowledge about the pacemaker, that pacemaker is usually implanted beneath the skins, usually close to the left shoulder. But nowadays, we have these MICRA pacemaker implantations performed percutaneously, so that these patients will not have a pacemaker being seen at beneath the skin, and this is a minimally invasive surgery that performed under local anesthesia. So nowadays we have lots of technological advancements in the interventional cardiology, and today I'll show you some of these percutaneous interventions, left atrial appendage occlusions, and MICRA implantations. So to conclude these talks, I'd like to share, this is the Hong Kong Cardiovascular Disease Prevention Society, established by myself and together with my friends, Dr. David Siu. So the society is largely for aiming to prevent some of these important cardiovascular problems. So last year we have performed this atrial fibrillation screening in our locality, and we have successfully screened a lot of elderly patients with underlying undetected atrial fibrillations, and they can receive free of charge medications for a short period of time as a bridging to eventual doctor visits in either the public or the private sector. So this is the end of my talk, and I would welcome all of you. If you have any questions, then feel free.
Thank you, Dr. Chan.
Thank you.
Dr. Chan, we have here one question from a attendees by the name of Evelyn.
Yeah.
And is it encouraged to keep a nitrolingual spray at home for patients with CVD to use during the attack of cardiac arrest?
Yeah, so cardiac arrest usually, of course, most of the cardiac arrests, if unfortunate, that usually they were suffering from coronary artery disease, but not every patients or persons with cardiac arrest is due to coronary disease. Sometimes they may suffer from cardiac arrhythmias. So of course, unfortunately, if you have underlying coronary disease and it's not completely revascularized or tackled, then by keeping a nitro spray can help to relieve the symptoms if unfortunately you have an acute attack. But usually they would only relieve the symptoms, but not to protect it as a long term. So that means if the symptom is not relieved, then you should visit the closest A&E departments or call your cardiologist as soon as possible when you have symptoms. But if a person's already developed arrest on site, the only thing that you could do, if you know CPR or if you have a AED available, then of course you apply the AED and also call for help. But otherwise, nitro spray in cardiac arrest situation might not be helpful because the person is already having a complete loss of consciousness. Did I answer the questions of Evelyn?
We don't have feedback from the attendees. So is there any other questions from the attendees? We got a couple of minutes left. We have one question. It's coming to the Facebook. That's why, Dr. Chen, you will not get it on the screen because it's coming to the Facebook.
Okay.
I'm going to read out to you. It's from Kashminda Singh, and the question is, if the LDL is more than 4.9 needs treatment, what about triglycerides and total cholesterol?
So for people with LDL level high, then of course we are more focusing on cardiovascular disease. But triglyceride is not helpful. Is too high level will be also harmful, but not in the aspects of coronary artery disease. If the triglyceride level is too high, usually the risk of suffering from pancreatitis, inflammations of the pancreas, will be much higher. So of course, if the triglyceride level is higher, of course we recommend with a dietary restrictions. If that fails, and if the persistent high triglyceride, we will initiate treatments to lower the risk of the acute pancreatitis, usually in the forms of the fibrates rather than statin, because statin is more focusing on the LDL level, and fibrates can lower the triglyceride levels. Well, some people, of course, they also focus on the total cholesterol level, but total cholesterol levels includes the summations of these LDL level, HDL level, and also some of the intermediate density lipoprotein or very low density lipoprotein. So it is less accurate reflections of the overall risk of cardiovascular problems. So largely we focus on the treatments target, we focus more on the LDL level rather than the total cholesterol level.
Thank you, Dr. Chen.
Yeah.
I think any further questions? I think we're just exactly almost on the dot. Thank you, Dr. Chen. And just for information for all the attendees, today's sessions will be uploaded onto the YouTube, and we'll be sending out the link for the YouTube in a day or two, and obviously which we are free to share with your friends and for you to recall whatever that you missed, because I think there's a lot of information that will be available just now. So once again, thank you, Dr. Chen. I think this has been a very, very useful event, and probably you might have saved some lives here right now. Okay, so anyway, once again, thank you, Gleneagles Hospital, for the event today. And again, Dr. Chen, thank you for your time. And we'll see you again. Thank you.
Thank you. Have a nice evening, everyone.
Thank you.
Cheers.
Bye.
Bye-bye.